Love this podcast? Support it and sponsor today. Simply head to ozcastnetwork.com for details.
Dr. Travis Brown, what is This Medical Life all about?
This is the pursuit of knowledge as we learn about diseases from the ancient times to the present day. These are the stories of medicine.
Dr. Travis Brown, I have a number of clients who are women of a certain age who I've noticed this year more than ever have just been upfront with the symptoms of menopause they're experiencing. I haven't been as acutely aware of that before. I don't think it's just because we've been planning this episode, but there is a culture shift of things being less taboo and just being matter of fact and being talked about.
It is. There is an element of menopause that if we look at the history of it, there is sort of almost a shame associated with it. This is something that is not feminine. It reduces femininity. And the challenge that we're looking at is when I was putting this together, it was actually how much I didn't know about menopause. And I think we're coming to terms with this today. And if we were going to have something if this was a podcast from the 1940s, two men in their 40s and 50s talking about menopause, it would just fit. Do you have a 1940s voice that you can do it?
Yes, Doctor. I would like to hear what you have to say in a learned fashion about this topic of great import to the many people listening, especially of the female type.
And this is how it is, see? And that would be almost, looking at history, that's how it was. And we will touch on that. So those quotes will come back to us. But I wanted to get some experts to help us navigate this really complex area for women, to help us for understanding symptoms, understanding how it is managed, and what is the path forward for women. So we've got some experts. This is a large episode, but we have some wonderful guests to help us, guide us through menopause and the management.
Lights, camera, action. Niki Bezzant is a multi-award-winning New Zealand writer, a journalist, speaker and author with her book, This Changes Everything, The Honest Guide to Menopause and Perimenopause, published in 2022 by Penguin Random House, has topped the bestseller list in New Zealand. Niki's been involved in New Zealand media for more than 20 years, including positions such as the editor of Thrive magazine, the health editor of Woman magazine, and can be regularly heard on Radio New Zealand's The Panel. Niki's an expert on the topic of menopause and midlife health for women. She's passionate about women's health and especially empowering women in their midlives. And Niki's our guest today here on This Medical Life podcast. Niki, welcome from across the ditch.
Thank you very much for having me.
Now, Niki, your book took 2 years to research and write. What started this journey for you?
I guess it started because I was sort of in that age group. I was 49, I think, when I started this, and I was just starting to hear this conversation about menopause and perimenopause, and it was figuring in my own life, and I realized that even though I had written about health for decades, I didn't know anything about it, really. It was a bit of a blind spot for me. And I think that was a very common experience for many of us, is that we get to this stage of life and we actually find that we know next to nothing about what's going on with our hormones and with our health, and this whole menopause thing is a big mystery. I think it had been framed as something that happens to old ladies. In my mind, anyway, that's what it was. And so I started to learn about it, and discovered there wasn't much information, really, not much good quality information that related to me, to my generation. So that's kind of where it started from.
Mm-hmm. Is there much history about menopause before the 20th century?
I mean, menopause has always existed. Women have always gone through it. It's been framed in different ways throughout history. And when I delved into that, it was pretty interesting. Some of the suppositions that people had about menopause and the attitudes about it and the treatments, I say that in inverted commas, for it, are pretty horrific. So it's always been there, and but it's just that it has never really been talked about in general discourse in society very much. It's always been a little bit in the shadows, I guess you could say.
Actually, just in the very introduction to this episode, I mentioned in my day job, I have a number of clients who are women of a particular age, and this year more than ever, when they've been experiencing symptoms related to menopause, they've been open in discussing it, which is not something I've noticed much over my 20 years in my consulting. Is this attitude change that you're talking about?
I think so, yeah. I mean, I've noticed even in the year and a half or nearly 2 years now since my book came out, there's been a lot more open conversation about it, which is an excellent, excellent thing. And I think it's a generational change. Gen X women, I mean, our generation, are actually not the kind of women who are going to go and sit quietly in the corner, and stuff. We want to talk about it, and it hasn't been talked about before. And so what I have found in a lot of the work that I'm doing now is actually speaking on this topic, and in workplaces in particular. Once you start a conversation about it, women want to talk about it and want to open up about it and keep that conversation going. So it is a real change, I think, in terms of our whole approach to it as a society. And I think that only can be a good thing for future generations coming through.
Yeah. You touched on early treatments of menopause. Can you just give us a little bit of an insight to what kind of treatments you're mentioning?
Well, yeah, I mean, you probably don't need me to explain to you that the misogynistic roots of early medicine, the things that were baked into medicine in the early days, which was this idea of the woman's body as inferior, as a defective version of a man's body, and so women who. I had some very interesting interviews with medical historians on this topic, because women were seen as kind of a little bit mad and dangerous anyway back in the days of early medicine. Talking the early Greek physicians, and so stretching all the way into probably even the 19th century, there was this idea that there was a buildup of blood. That blood is bad. Women are suspicious. First of all, there was the wandering uterus theory, where they believed that the uterus kind of wandered around inside the body, causing problems, and the only way to sort of calm a woman down was by getting pregnant. Basically, there was that. And then when women stopped, they knew that women stopped menstruating at a certain point. But they were deeply suspicious about what happened to all of that blood. Did it just build up inside the body? This idea of bad blood. So there was a lot of bloodletting that went on in various forms, which is kind of a sort of a treatment for a lot of things back in the day. And then there were some really horrific things like clitoridectomies, believe it or not, because of what they perceived to be excess heat building up in the body, which, I mean, kind of makes sense if you think about menopause and hot flushes and things. They were identifying the symptom, they just weren't really treating it in the most appropriate way. And then, of course, they identified a lot of the stuff that happens to women in menopause as hysteria or forms of hysteria. And often women got put into asylums and treated as a mental health patient, which is a bit alarming.
I'll just mention briefly, if you're interested, you mentioned the wandering womb. Series 1, episode 19. We touched on that in our endometriosis episode, Travis.
Oh, amazing! Yeah, it's such a funny theory there, but it's not funny really.
All right. The treatment of women throughout medicine is certainly something that's we've had lots of challenges in trying to how to present that. But look, what changed then in the 20th century? Because we mentioned 19th century. What changed?
I guess that their kind of understanding around hormones started to become a little bit more known. They identified that there was this hormonal thing going on, and then the development of hormones as therapy in the early part of the 20th century. So the very early forms of HRT were developed. So that sort of changed the game a wee bit in terms of menopause treatment, I guess you could say. Yeah.
I saw some of the marketing campaigns for HRT in the early days. Can you tell us a little bit about that?
Yeah, I mean, again, we're reflecting society here, but the marketing around HRT was very often aimed at men. aimed at the husbands, because of course every woman had to have a husband, and menopause, they framed menopause as something that made women much more difficult to live with and much more trouble for their husbands. And so if your wife was to take this hormone therapy, she will be much easier to live with and much more charming and sweet, and she'll be the old person that she used to be. That was the kind of the tone of a lot of the marketing, and it's hilarious to look at. But there's quite a bit of that around, particularly from the sort of 40s and 50s, that sort of stuff of, she will once again become charming and sweet.
Now, there is a book from 1966, an American gynecologist, Robert A. Wilson, who wrote Feminine Forever. Now, we have some quotes from this that I want Steve to read just before I throw into a few questions.
Many physicians simply refuse to recognise menopause for what it is, a serious, painful and often crippling disease. Every woman alive today has the option of remaining feminine forever. No longer need she fret about the cruel irony of women ageing faster than men. With treatment, her breasts and genital organs will not shrivel. She will be much more pleasant to live with and will not become dull and unattractive.
Is this book representative of women's health at the time? Where does this fit?
I don't know if it's representative of women's health at the time. I think it's probably representative a little bit of society at the time. This idea that, you read that very well, thank you. The idea that the ideal woman is a fertile woman of reproductive age, and that if you lose that fertility, then you are basically diseased. He framed menopause as a disease, which is, bonkers. It's a natural transition that happens in the life of every single female. But he had this idea that it was, to frame it as a disease state means that you can treat it as such. So, yeah, it was deeply, deeply misogynistic, but not surprising probably for the times.
Can I, with looking at that, did Wilson have a vested interest in HRT?
Yeah, actually, it has. It didn't say it at the time. He didn't declare it at the time, but it has been discovered later that he was being paid by the drug companies, by a couple of the drug companies, I believe, to write that book. And the book was hugely popular. And I gather that the sales of HRT really spiked after that book was published. There was just so much that was wrong in that framing of menopause as this terrible problem of decay that needs to be treated as a disease. He wasn't wrong that women were suffering, but actually the whole idea that you're not feminine if you're menopausal is just so offensive.
Just a footnote, as history repeats, very similar with our Andrew Wakefield episode, he had a secret vested interest in his own mum's or measles vaccine, didn't he? So
yeah, no, it's follow the money.
Repeat, yes.
Yeah, it's shocking how often that happens, but it's a real shame that it happened at the expense of women.
And now this touches on HRT is a controversial topic. And look, there's benefits that have been reported. There's been detrimental effects that have been reported. In the 1980s and 1990s, there was some, it said it helped prevent heart disease and osteoporosis, but then there was increased risk of breast and endometrial cancer. You looked at this in your research. Is this accurate where this HRT sits?
It's an interesting topic, HRT, and I think it is really. I did a kind of quite a big section in the book about the history of it, because I think it is really worth delving into why we have this idea that in the back of our minds, a lot of us still have got this idea that HRT is dangerous, that there's a risk of HRT, of breast cancer in particular, from HRT. A lot of it stems back to the Women's Health Initiative study, which was in 2002, was halted early, but back before that. They had actually identified that HRT was pretty useful. They had already knew, in the 80s and 90s that HRT was really good treatment for the symptoms of menopause, for hot flushes and night sweats, and that it was protective potentially for the heart and for the bones. It was actually approved as a treatment for osteoporosis, I think in the late 80s. So they knew that there were some good things about it. What they had found, I should take a step back, in the in the 60s, when in Robert Wilson's era, they were just prescribing estrogen willy-nilly, like just estrogen on its own, unopposed. What they learned, I think, in the 70s was that was not a good idea, that you needed to have a progestin as well, progestogen as well. So you needed to have that estrogen needed to be buffered by a progesterone component. So then they developed combined HRT, so the two things together, progesterone and estrogen, and then things rolled on. And then so in the 90s they thought, well, we know that HRT is useful for these things. Why don't we have a look and see if it could be a preventive treatment for a bunch of other stuff? And so they started this big trial, the WHI, the Women's Health Initiative. And that was not really looking at the effectiveness of HRT, because they kind of already knew that it was effective. It was looking to see what other things could we benefit from by prescribing HRT. So it was a big trial, but they halted it early after only 5 years in 2002, because they'd identified an elevated risk of breast cancer amongst some of the participants. Unfortunately, what's come to light since is that the way that was interpreted and the way that it was reported absolutely at that time was very misleading, and really did a big disservice to generations of women, probably, because it meant that women threw away their pills. It meant that doctors stopped learning about HRT. Doctors stopped prescribing it because they were worried it was doing more harm than good. And, a lot of women were just left on their own to deal with their menopause symptoms because everybody was so afraid of HRT.
Mm. Now, you discuss with a number of women in your speaking capacity about menopause, about perimenopause, and from your perspective, where do you think we're sitting currently with the management and how, I guess, medicine and doctors are approaching patients with menopause?
Yeah, it's a little bit patchy, I would say. And what we know, I should say, to follow on from that HRT thing, what we know now about HRT is that it is a very effective treatment. It is a highly effective treatment for the main symptoms of menopause, and it's kind of the gold standard when it comes to hot flushes. And it's also a really safe treatment. So we know from that WHI data being reanalyzed and re-looked at, and new data coming through, and also different formulations of HRT being developed, that it's really safe for most women, especially if you are taking it according to the guidelines, which are to start it before the age of 60 or within 10 years of your last period. So that's the kind of ideal time to be doing your HRT treatment. And that's the time that most women will be doing it. The WHI study actually looked at older women. It was the average age of those women was 63, which is well past menopause for most women. And it's not a time that you'd be starting HRT typically. So there were a lot of things wrong with the methodology in that study, and that was one of them. Most women are starting HRT, if they are, in their, late 40s, early 50s, and that's entirely appropriate. And it's very safe for most women at that time. And there's no real reason to be on the lowest possible dose for the shortest possible time. All that kind of advice is outdated now. The advice is that you stay on it as long as you need to be on it. However, it's a long-winded way of us answering your question. I think amongst GPs in particular, that the knowledge and the confidence around HRT in particular is a little bit mixed, just because there hasn't been a lot of education that's gone on over the decades. And I think that's probably true in almost every country. And people have got this idea still from that outdated research that HRT is something to be avoided. And even some doctors still have that, which is a real shame, because it means that women really have to advocate for themselves quite strongly, and often are getting not misdiagnosed, but dismissed a little bit. Sometimes symptoms are dismissed. I keep hearing stories, and every week I hear stories from women who have been to the doctor with, pretty classic menopause symptoms, and have asked about HRT and have been given antidepressants instead. That happens all the time.
So look, on that, and we've got so many aspects of menopause to work through in the rest of this episode, I just want to pick up to finish today with you on any final thoughts or advice you'd like to share with general practitioners about menopause.
Yeah, sure. I mean, I don't want to bag on GPs, because I know you've got such a hard job. It's a really, really difficult job to keep on top of everything. But I would say that just with any woman coming to you who's in that midlife age range, and really it's 45 to, 60, anywhere in anything that she's coming to you with should be looked at least at some point with a hormonal lens. Just cast that over it, because there's very often a hormonal component to what's going on in our lives at this time. If you look at the lists of symptoms of perimenopause, for example, there are just so many things, and they affect every system in the body. And so it's really worth just having that little question in your mind: could there be a hormonal component here? Because you could come upon the key to what's going on, and make that woman's life a lot better by just addressing that.
Niki Bezzant, thank you, and thanks for joining This Medical Life.
It's a pleasure.
Dr. Carmel Reynolds is a general practitioner with Adelaide Healthcare who has a particular interest in women's, child and adolescent health. Dr. Reynolds is part of the Adelaide Pelvic Pain Network and is the South Australian Northern Territory board member on the Australian Menopause Society. And Dr. Reynolds is our guest on This Medical Life today. Welcome, Carmel.
Thank you very much for having me.
Carmel, I wonder if we could start by you giving us the medical definition of peri and post-menopause.
Excellent, of course. I'm going to steal a line from, I think it was from Professor Baber's talk, that technically menopause refers to a day or a week in a woman's life where she has her last or final menstrual period, and it marks the end of reproductive life. We say that someone is postmenopausal if they've had 12 consecutive months of no periods and is the appropriate age. Perimenopause is the transition period leading up to menopause, and it's defined as being the period of time from when there is a persistent variation in cycle length of more than 7 days. And these definitions are the ones that were agreed upon in the stages of reproductive aging workshop criteria, or what we call the straw criteria. So the menopause transitions, that is the time from the start of perimenopause until 12 months after your final menstrual period, can last about 4 to 8 years. This definition has some complexities because it relies on people having vaginal bleeding. And for those women who have amenorrhea due to contraceptive use or have had a previous endometrial ablation or hysterectomy, then we need to rely on other symptoms that relate to hormone fluctuations or low estrogen that happen over this time. And there is also a group of women for whom menopause is a very sudden transition due to surgery or chemotherapy. So it's important we don't forget to include those in our definitions.
Is there a particular age that is expected that someone will enter menopause?
So the average age in Australia is around 51 to 52 years of age. But the menopause transition, if we look at that time, can sort of start in your early 40s, and certainly there are women who are closer to 60 by the time they go through the menopause transition. So it is quite variable.
What are the common symptoms of menopause?
So I think importantly, they vary really widely for different women, and they vary over time as you progress through the menopause transition. So for around 20% of women who are incredibly lucky, their periods just stop and they don't experience any other symptoms, although I would say eventually they do develop the genitourinary symptoms related to menopause. And for another group of women, the symptoms can be really severe and debilitating and have a significant impact on their lives. And most people fall somewhere in the middle. Early in the menopause transition, there is a wide fluctuation in estradiol levels, which means you can have symptoms related to estrogen excess, so things like mastalgia, heavy menstrual bleeding and headaches. And at other times, you'll get symptoms of estrogen deficiency, of which the most common ones, what we call the vasomotor symptoms, but the sort of most commonly known ones, known more colloquially as hot flushes or night sweats. There can be sleep disturbance associated with those vasomotor symptoms, but there's also fatigue, brain fog, mood changes, including anxiety and depression. A lot of people complain of arthralgia and myalgia, a loss of libido, and genitourinary symptoms. When I say that, what I mean is vaginal dryness, urinary frequency, issues with urinary incontinence, and dyspareunia. And the vasomotor symptoms on average last about 7 years, but for some women, unfortunately, they are lifelong. And I guess later post-menopause, the predominant symptoms are the genitourinary symptoms.
Are there any uncommon symptoms that we would like to flag?
Look, I find this really tricky to answer because I see so many women with such a broad range of symptoms that they attribute to menopause. It's kind of hard to sort of pick out the ones that are the more uncommon. But I guess I worry about the fact that there are common symptoms of menopause that women aren't expecting. And those symptoms are typically the ones related to mood, cognition, and weight. Many women present to me with symptoms of brain fog or impaired executive function, usually worried that they're developing dementia. The exact cause of brain fog is unknown. What I can do is reassure women that it's not an early sign of dementia. It's not a risk factor for dementia, and it's a common symptom of menopause, and it tends to get better over time. We're not really sure what causes it. But the other thing that women present with that they really don't expect is the increased vulnerability to mood disorders that happen at this time, particularly anxiety and depression, which can blindside many women and can occur for the first time in menopause, although it is more common in women who've experienced hormone-related mood disorders in the past, so women who've had premenstrual syndrome, premenstrual dysphoric disorder, or postpartum anxiety and depression. And I think it's a little bit different in terms of how we normally would manage a mood disorder, in that it is important to consider menopause hormone therapy as part of our treatment algorithm in that sense. Weight gain in general for everyone is difficult, particularly difficult for women. Society's views on people and being overweight are really entrenched, and it's hard to shift that. What I can say is that if a woman does absolutely nothing differently in terms of diet, lifestyle, and exercise at menopause, then they can be expected to gain about 0.5 kilo of weight per year. And there's a change in weight distribution. So it tends to be moved from more classical sort of hips up into more central weight gain. This has huge impacts on confidence and self-worth, and I wish it didn't, and it has some metabolic effects. And I'd love for women to be able to actually just be out and be active and what they weigh not be a problem. But unfortunately, what I do see is it does restrict a lot of women in terms of what they do in their lives. And I would love to see that disappear.
How long do symptoms typically last for?
So again, highly variable, but the average the symptoms last would be about 4 to 8 years. But I think it's important we remember that there are a group of women who these symptoms are lifelong. The genitourinary symptoms do tend to be long-term, and I think it's really important that we ask women about them. They often won't bring them up on their own, and we discuss treatment options because they're actually quite easily treated.
Can you tell us a little bit about genitourinary symptoms? What symptoms are we specifically wanting to ask the patient?
Yeah, so asking about vaginal dryness, and that can be irritation, itch, issues with intercourse. So dyspareunia is a really common one that people don't talk about, and increased issues with urinary incontinence and urinary frequency.
Now, looking at the age distribution, when someone is considered maybe early menopause, what age bracket are we thinking, and what investigations do we do for those patients?
So I would say that someone has early menopause if they're between the age of 40 and 45 with classic symptoms. And I would do some basic blood tests in those women to confirm that what we're dealing with is menopause. I would check a follicle stimulating hormone and repeat it 4 to 6 weeks later to see if the FSH is high. And I generally check their thyroid function as well as another cause of vasomotor symptoms. I also think about risks for obstructive sleep apnea, because a lot of the symptoms, apart from what is happening in terms of periods, are very similar. So, in terms of night sweats, poor sleep and fatigue. But other than that, in that age group, I wouldn't go any further. For those women who we think have premature ovarian insufficiency, so those women under the age of 40, then we do need to look at more carefully. So that would be described as having 4 months of amenorrhea, oligomenorrhea under the age of 40. And again, the diagnosis is made on measuring follicle stimulating hormone, 2 occasions, 4 to 6 weeks apart. It is really important we don't miss these women because there are significant implications for fertility, and they have a higher risk of cardiovascular disease, osteoporosis, and a reduced life expectancy overall if we don't treat it. POI it can be a little bit complex, and I think is a whole discussion in itself. And I think the really important takeaway is that if you're investigating amenorrhea or oligomenorrhea in women under 40, then you need to be thinking about it. And there is a really good white paper from the International Menopause Society that goes into it in a lot more detail.
Sorry, what was an acronym used?
Sorry, POI, apologies, premature ovarian insufficiency. We don't call it failure anymore. And I think importantly, the insufficiency highlights that there is actually still a potential risk of pregnancy in these women. And that needs to be considered as to what's important to that woman.
Now, looking at if someone comes in the classical age distribution and they have the classical symptoms, is there any investigations or workup you do for those patients?
So there are no investigations I would do to make a diagnosis of menopause in that age group. But when I see someone present with those classical symptoms, it is a trigger for me to start thinking about chronic disease screening and prevention and cancer screening. So I want to make sure that their breast, cervical, and bowel cancer screening is up to date. And then I'll have a look at their family history and personal history for risk factors of cardiovascular disease and diabetes and osteoporosis. So I do a blood pressure check, fasting lipids, diabetes bloods, and I would look at whether or not they should have a bone mineral density measured now or plan for when we would do that in the future. But I think importantly, 2 things. Any heavy or prolonged bleeding always needs to be investigated. So if they're presenting with perimenopausal symptoms with heavy bleeding, we need to actually be looking into the cause for that. And we always need to think about the need for contraception.
I'm just curious, with that being a trigger to take stock of the general screenings, etc., is that because it's as good a milestone in their life as any time, or are they on the precipice of moving into an area of higher risk?
So they are on that precipice of moving into an area of higher risk, and the hormonal changes that occur around menopause do increase our risk of things like cardiovascular disease and stroke and osteoporosis.
Are there treatment options available for people who are perimenopausal and postmenopausal?
Oh, absolutely. And we have quite a range of options in Australia, less so in New Zealand, but we're really lucky in Australia with the range that we have available. Much like everything else, when we're talking about treatment for menopausal symptoms, there's non-pharmacological and pharmacological options. In terms of non-pharmacological treatment, the recommendations are really those for health in general. So don't smoke, limit your alcohol intake, eat a good range of fresh foods, lots of plant-based foods, get enough sleep, maintain social interaction, and keep up your exercise, aiming for around about 150 minutes of moderate intensity exercise per week. But in terms of bones, actually looking at least twice a week doing some load-bearing, what I'd call osteogenic exercise. The non-pharmacological options for vasomotor symptoms are a bit paternalistic. So they talk about wearing layers of lightweight clothing, managing your environment, making sure you have good ventilation and temperature control, avoiding spicy foods, maintaining a normal BMI if possible. Some of those are more appealing than others, in my opinion. I don't want to be getting about in layers of linen and never eating a curry. But also some things like ventilation and air conditioning are completely beyond individual control in certain workplaces, for example. As is clothing. If there is a uniform for your workplace, it would be ideal if it would be something that would allow you to wear layers, but it may not always be. But the evidence is that the best treatment for bothersome menopausal symptoms is menopause hormone therapy. The language here is really important. So hormone replacement therapy is what we would term treatment for conditions like premature ovarian insufficiency. Whereas menopause hormone therapy is when we're talking about using hormone therapy for managing menopausal symptoms as part of that normal transition in reproductive life. There is a wide range of hormonal options available. And for women without a uterus, estrogen therapy can be used on its own. For those women who have an intact uterus, including those who've had an endometrial ablation, combined hormone therapy with estrogen and progesterone is needed. And the purpose of the progesterone component is to avoid increasing the risk of endometrial cancer due to unopposed estrogen. The combined menopause hormone therapy is then broken into sequential and combined therapy. And we would use sequential therapy. So that's where we would use 2 weeks of estrogen therapy, usually with 2 weeks of combined therapy for the first 12 months for those women who haven't had 12 months of amenorrhea. And then beyond that 12 months, or for women who present after 12 months of no bleeding, then we would use continuous therapy. Once you've established which hormone therapy is most appropriate, whether it's estrogen alone, combined sequential, or combined continuous therapy, then you have quite a wide range of choices of transdermal options, oral options, the use of the levonorgestrel IUD for the progesterone component, and topical vaginal estrogen treatment for genitourinary symptoms. And it's really about assessing risk and individualizing treatment, working with personal preferences, as well as always considering whether or not there is still a potential for pregnancy. With the exception of the levonorgestrel IUD, menopause hormone therapy is not contraceptive, and we need to remember that. And then we have our non-hormonal options. So there's the ones that we've been using for some time, which includes low-dose SSRIs, the SNRIs, gabanoids, clonidine, oxybutynin would be the most commonly used agents that we have that are not hormonal for those women who can't have hormonal therapy or would prefer not to use it. And there is a new agent coming to Australia. It's currently available overseas. I cannot figure out how I'm meant to pronounce it, so I apologize, but it's fezolinetant. It's a neurokinin antagonist, which acts centrally and is effective for reducing hot flushes. And it'll be a really good option for those women who can't have hormone therapy or would prefer not to and have tricky vasomotor symptoms, but it is likely to be very expensive. I think it is around about $400 a month in the US. So I'm hoping we can do better than that.
So we're moving from the keyword of hormone replacement therapy, so HRT, to menopause replacement therapy. That's sort of the transition?
Taking the word replacement out of it, so menopause hormone therapy.
Okay. Now, there is a concern in the past about increased risk of cancer. Is that valid?
Look, I do think the concern is valid, and there are 2 cancers that are important to consider when we talk about menopause hormone therapy. So one is breast cancer, and that's the one that gets talked about the most, and the other one is endometrial cancer. In short, the risks associated with menopause hormone therapy and breast cancer have been really overstated, but it's important that we actually discuss the risk and we're truthful about what the risk is. So I think there are some really important factors involved in this. In Australia, 1 in 7 women will develop breast cancer in their lifetime. And the risk of breast cancer in association with menopause hormone therapy depends on when it started, how long it's used for, whether we're using combined menopause hormone therapy or estrogen on its own, and which progesterone we choose to use. So for women using estrogen therapy alone, there are conflicting studies either saying that there is a negligible increase risk or possibly a small reduction of risk in other studies. And the consensus is that there's really very little, if any, increased risk of breast cancer in that group. I tend to use the numbers when I'm talking about combined therapy. I tend to use the numbers from the collaborative group on hormone factors in breast cancer. I find that they're kind of easy to conceptualize. So for women who are taking continuous menopause hormone therapy for up to 5 years, age 50 to 59, the risk of breast cancer increases from a baseline of 3 per 50 women to 4 per 50 women. So that's 1 extra case per 50 women. When we look at sequential combined therapy up to 5 years, then that risk is 1 extra case per 70. And this is where the language, I think, gets quite tricky. So if we extend that use up to 10 years, then we double the risk. But what we're talking about is 2 extra cases per 50 women or 2 extra cases per 70 women. So the numbers that were increased by are actually quite small. And I think importantly, menopause hormone therapy doesn't increase risk of mortality from breast cancer. And not all progestogens are equal. So the data we have so far would support that micronized progesterone, so the most biosimilar progesterone we have, or dydrogesterone are safer in terms of breast cancer risk than the other progestogens. Unfortunately, menopause hormone therapy is contraindicated in women who have breast cancer or have had breast cancer. I guess my exception to that would be if someone was really looking at end-of-life care and was having a dreadful time with their vasomotor symptoms, but obviously that's incredibly nuanced and a very particular group of women. But it's really important we look at those risks in the context of general risk for breast cancer. My favourite sort of educational tool for explaining this is an infographic that the British Menopause Society has that looks at risks in comparison to menopause hormone therapy. So what we do know is that exercising for at least 2.5 hours a week significantly reduces your risk of breast cancer, while smoking, drinking more than 2 standard drinks a day, actually confers similar risks to menopause hormone therapy taken over 5 years, and having a BMI over 30 increases your risk by about 24 additional cases per 1,000 women. So compared to 4 extra cases per 1,000 women taking menopause hormone therapy. I hope that makes the breast cancer risk a bit clearer. The other cancer that doesn't get talked about as often is endometrial cancer, and it doesn't get talked about as often. And unopposed estrogen or underopposed estrogen increases your risk of endometrial cancer above the baseline risk. And the reason it's important that we use the right dose and the right regimen of progesterone for the dose of estrogen is so that we don't increase that risk from baseline. So we can't get rid of the risk, but we can certainly stop us from increasing it. And that dose, unfortunately, is probably not fixed between women. This Australian Menopause Society has some guidance on their website to help us choose the right dose and right type of progestogen for dose of estrogen. But I think the important rule of thumb is that if there's any unscheduled bleeding or prolonged bleeding on sequential therapy that continues beyond the first 6 months of starting therapy, it needs to be investigated.
So after discussing with a patient all those risks and the balancing out, can I ask about the response for patients who actually have the therapy? Do they find it useful? Is it a try and see and they find it beneficial? How does that go?
So for most women, I've found the ones that present with bothersome vasomotor symptoms in particular, menopause hormone therapy is a very effective treatment. It does also have some benefits for those other symptoms that I talked about earlier. But I think we need to set expectations at the start. We are probably not going to get rid of all of the symptoms. So our aim is to improve them and to improve quality of life. And the treatment works well. I'm sorry, did that answer the question?
Yeah, no. It's just trying to, I guess, for the patient saying, oh, you're going to be completely okay and this will be, but sometimes can some of the treatments almost exacerbate some of the symptoms?
Yes, they can. And certainly I try to ask women to give the treatment 3 months to see if it's actually going to be of benefit to them. The 2 things I tend to find people, or 3 things that people tend to come back for help with. The first one would be mastalgia, which we can manage by altering the doses, usually of the progestogen. But I tend to try and get them to go with it for the 3 months to see if it settles down. It usually does settle over time. Bleeding can be annoying in the first 3 to 6 months. Usually in the first 3 months, people may get some unscheduled bleeding or heavier bleeding, which can be annoying to manage, but will usually settle over time. And the other one is I find progestogens can be quite unpredictable in terms of their impact on mood. And for some women, we need to change the progestogen. I usually say, look, if you feel a little bit wobbly, try to continue with it and give it a little bit of time. We'll see if it settles down. But if it's actually making you feel angry or miserable or you're hating it, then we try something different. We have lots of options available to us.
Are there any alternative medicines or therapies that you know of that help?
So I'm not a naturopath, so I can't give particularly detailed advice in this area. There are some great resources, particularly on the Jean Hale's websites. They have a great naturopath as part of their team, and the AMS website does have some further information. The issue with most of the natural therapies is that there's very little evidence of benefit, but equally there's also little evidence of harm. And I think if people want to try things and see if they work for them, then by all means give it a go, but give it a time frame. So say, look, let's see if we actually feel any better over 3 months. I didn't mention earlier, but I use the scorecard, the symptom scorecard from the Australian Menopause Society website to help people monitor their symptoms over time. Black cohosh has in trials been shown to offer some benefits, but does have some side effects, and it has been implicated in some cases of liver injury, although the jury is not entirely convinced on that. But that is something to consider if someone does have pre-existing liver disease. The soy and plant phytoestrogens products, vitamin E and flaxseed oil, have all shown some minor benefits. And in the trials that I have had information about, evening primrose oil, dong quai and wild yam haven't shown any benefit.
We will put the link to the society in our show notes, but what is the web address? Carmel?
It is menopause.org.au.
Lovely. Final question. Other GPs listening in, have you got any final thoughts for them about managing patients during peri and post-menopause?
I guess the most important thing is individualize your approach to the person in front of you. Listen to what the impact of the symptoms are having on their life and come up with a plan together. And use that consult as a trigger to work on their chronic disease prevention and risk factors and encourage health-promoting lifestyle choices. Make sure their cancer screening is up to date, and please don't forget contraception.
Dr. Carmel Reynolds, thank you for joining This Medical Life.
Awesome. Thank you very much. It was lovely to talk to you.
Dr. Ashley Winter is a board-certified urologist and sexual health specialist. She received her medical degree from Rutgers, New Jersey Medical School and completed her residency in urology at Weill Cornell Medical Center. She specialises in sexual dysfunction as well as practising in general urology. Dr. Winter is also very active on social media, Twitter or X and Instagram, providing educational posts as well as a co-host of the Full Release podcast, which is all about health, sex, relationships and comedy. Dr. Winter's our guest here on This Medical Life podcast. Welcome, Ashley.
Well, thank you so much for having me. It's great to be here.
Yes. Well, look, today we're actually focusing on menopause, both peri and post. Now, is this something you've had to deal with much in your clinical work?
Yeah, a great question. So, the topic of menopause did not come up much during my residency training. But then when I did my fellowship, which is, at least in the United States, the only fellowship in both male and female sexual dysfunction, right? So, I'm not sure how it compares to Australian medical training, but right after medical school, we do a residency and then you can do a fellowship. You certainly don't have to. And so after my 6 years of urology residency, then I did the 1-year fellowship in male and female sexual dysfunction and learned quite a bit about it then. I think that people traditionally think of menopause care as within the sphere of general practitioners or gynecologists and not urologists. But what I found was, being in practice as an attending in my first post-training position was that the effects of menopause really factored into basic urologic care every single day. So what are some reasons, right? So one of the most common referrals that urologists get is for what we call microscopic hematuria. Small amounts of the blood in the urine that you don't see that come up on a screening urine analysis test done for some other reason. And one of the primary causes of microscopic hematuria, one of the common benign causes is genitourinary syndrome of menopause, right? So the changes associated with low estrogen state and how that causes, friability of the urethra and the urethral mucosa, inflammation in the bladder, prolapse of the urethral meatus. So, on a very, very frequent basis, seeing people who were referred, of course, we do the cystoscopy, right? We look in the bladder and we do the CT scan or ultrasound, ruling out cancerous causes of the blood in the urine, or ruling out things like, kidney stones or bladder tumors. But in the overwhelming majority of cases, this microscopic hematuria in postmenopausal women was really due to their atrophic tissue changes. And so that was one component, right? And then the question is, are you able to appropriately manage and counsel patients about that? Other things. So I very frequently see postmenopausal women for recurrent urinary tract infections. That very, very often is a direct consequence of menopause, right? Of genitourinary syndrome of menopause, because we know that urinary tract infections increase in frequency after menopause, and that is associated with changes to the vaginal microbiome due to low estrogen state. And then urinary symptoms like bladder urgency, bladder frequency, urge urinary incontinence, bladder pain, right? So we also know that a lot of those medical conditions increase in frequency after menopause, and that a low estrogen state can lead to bladder inflammation, can modulate the threshold we have for bladder sensitivity. So urgency frequency can be a direct consequence of low estrogen state. To be really nerding out on this, right? There's animal studies showing that when estrogen levels go down, actually the mechanoreceptors in the bladder increase in density, right? So your bladder actually becomes more sensitive to filling with low estrogen. So, it was just wild to me that microscopic hematuria, recurrent UTIs, bladder pain, bladder urgency and frequency, urinary incontinence, all these things in a tremendous number of patients that I was seeing on a daily basis was a direct consequence of menopause, and that I had not been trained about that in the core of my urologic training, right? And it's like wild to me when I think about the fact that, after years and years of lectures, trainings, board exams, I had probably done hundreds of hours of education about prostate cancer, which is very important. And as a urologist, I see many patients for that, for example, but almost nothing about menopause. And that had a direct consequence. So that is my very long answer to that very great question.
Well, just looking at that then, if you are encountering these patients, how did you manage them?
Wonderful question also. So, again, wearing the hat of like a general urologist, right? And in that clinic, that's what I was primarily functioning as, and taking referrals from general practitioners, for general urology type referrals. I wasn't doing kind of more comprehensive menopause care in the sense of like what people would call menopause hormone therapy, right? Which are use of hormones to raise the blood levels of estrogen and progesterone after menopause, with the specific intent of managing systemic effects of menopause, right? So like vasomotor symptoms, bone mineral density loss, right? Those are systemic issues and systemic treatments associated with menopause. So that wasn't my hat, and that's not what I was doing, even though I am happy to provide that care now in a different clinical roles. But something that I did do very, very frequently, and a menopause related treatment that I instituted very, very frequently, is what we call like localized hormone therapy. Meaning either a vaginal and vulvar estrogen cream, or suppository, or alternatively, at least in the US, there's FDA approved intravaginal DHEA, which is a precursor to estrogen and testosterone within the vaginal epithelium and functions as a localized hormone treatment. And the specific intent with those is that they don't raise the blood estrogen levels or testosterone levels, so they're not considered a systemic treatment. Because of that, they're also extraordinarily safe. And by being a localized treatment in the vagina, they affect the vagina, the vulva, and the urethra and bladder, and really are the first-line treatments for the urologic manifestations of menopause. So very long way of answering that, right, is to say that I was prescribing some form of vaginal hormones, usually vaginal estrogen, all day, every day, not for my male patients, but all day, every day. And there were so many women leaving my office just bamboozled. Like, I was going to see this urologist about my UTIs, and I never thought I would leave with a estrogen prescription, but it was life-changing for so many people and addressed the root cause for so many people. And I can tell you, my entire office staff, from the medical assistants to the nurses to everyone, by the time I was there long enough, every single one of them could probably recite like a 10-minute counseling discussion about the risks and benefits and the literature and the scientific evidence behind vaginal estrogen. And they all loved it and also thought I was crazy. But yeah, so that's the way that me as a urologist was directly giving menopause care, but also fundamental urologic care. Because if I was treating that patient cohort, that postmenopausal female cohort, for bladder urgency, bladder frequency, urinary continence, recurrent UTIs, microscopic hematuria, without using vaginal estrogen, then in my mind, I would be using second-line treatments with less evidence, treatments with more side effects, so yeah.
I don't mind if you actually get into the details, as I'm a pathologist, so I'm happy, but what is the actual estrogen doing?
Yes, so this is a great question. So the primary thing that the estrogen does in the vagina is increase the vaginal wall thickness and increases the glycogen content in the vaginal epithelial cells. With that increased vaginal wall thickness and the epithelial glycogen content, there's more cell turnover, and there's more essentially food for lactobacillus. And so that change associated with the estrogen repletion, if you will, allows the lactobacillus, which are normal microbiome to have in your vagina, repopulate, right? So in the typical female postmenopausal, the lactobacillus actually go away. And when you give them vaginal estrogen postmenopause, so it increases that glycogen content, increases the vaginal wall thickness, allows the lactobacillus to repopulate, and associated with the lactobacillus, you have a reduction in vaginal pH to pre-menopausal levels. And that is really important because that whole environment serves as a barrier to the bacteria, like enteric bacteria, like E. coli, from entering, getting from the perineal region and the anus and getting into the urethra, right? Since females have a short urethra, obviously we know it's easier for bacteria to move up the urethra from external to internal and enter the bladder and cause a urinary infection. And so what the vaginal estrogen does in a very direct way is, again, reestablish the probiotic milieu, if you will, like your natural probiotic milieu, right? You don't need to take probiotics because estrogen will do that for you. Lowers that vaginal pH, and also just improves the like very physical elasticity, right? So less tearing, less injury, from basic things like wiping yourself or sexual activity. So that's like the key way that it improves urinary tract infections. And I would explain this to patients all the time because people are smart. And if they understand why they're taking something, they will be compliant with it, right? And if you just say, oh, hey, you're postmenopausal and you have UTIs, take this estrogen, like most people don't understand why, right? They don't put the two together. They're like, this is not an antibiotic. What does this have to do with anything? Or they might say, I'm not sexually active. Why do I need to put something in my vagina? And so you have to educate them, and that improves the compliance tremendously. And I would say, to any of your listeners, if they're thinking of making this a consistent part of their practice, or they have this prescription pattern as part of their practice and they find there's poor compliance with it, maybe even put together a little resource sheet that you send patients off if you don't have the time to do this counseling, just with like bullet points. Myself as a patient, sometimes when I start medications, the physician has a little resource sheet explaining the why behind a medication, and that makes all the difference to me. So that is part of it. In terms of the bladder urgency and frequency, as I mentioned before, actually, that the mechanoreceptors in the bladder wall are actually related to estrogen levels, and we know that sensitivity to mechanical stimulus is increased, and not in a good way, due to the lack of estrogen. And then also, bladder inflammation is increased in, like, on cystoscopy. If you look in a bladder with a camera, there's a very high incidence of women who have increased bladder inflammation just associated with going through menopause. So the bladder is a hormone sensitive organ, and so is the urethra. So it's not just the vagina. And then another thing I'll just say that's really important is that lubrication in response to sexual stimulation in the vaginal wall is a transudate. Again, when we're like nerding out, right? So you actually have to have arousal, and you have to have increased blood flow to the vaginal walls, and then that's a transudate of the increased blood flow to the vaginal walls that makes your lubrication. And if you have very thin atrophic vaginal walls from a lack of estrogen, you will not be able to become lubricated in response to sexual arousal. Even if, you're in the most perfect environment and you're on the best state of your life and you have the most sexy music on and you have the perfect relationship, it will not work if the estrogen is not there.
Well,
so
you can't even prescribe listening to Barry White. That won't even do the job.
Exactly. So the first, at least in the US, the first FDA indication for vaginal estrogen was actually for dyspareunia, right? Painful sex, not for any of the other things I'm talking about. And this is the reason why it works, because it improves that elasticity, but also it allows you to become lubricated. And unfortunately, no matter how much lube you use from a bottle, that attenuates throughout sexual activity, right? So yes. Yeah. So there's so many things it does. And the other thing, just so people aren't scared off by this topic, to remember is that low dose vaginal estrogen does not require any blood monitoring. You don't have to do any labs. You really don't have to titrate. I mean, you can, if you would like to, do a serial physical exam and check for a response on physical exam parameters associated with atrophy, but you don't have to. And in multiple studies, low dose vaginal estrogen has never been associated with breast cancer, uterine cancer, blood clots, cardiovascular events, none of that. And in the U.S., again, the North American Menopause Society, position statement on treatment of genitourinary syndrome of menopause is very clear that it's safe. Basically, for anyone at any age, the only time you're going to take pause is somebody who's actively on estrogen suppression, right? So like an aromatase inhibitor, and then you're going to talk to the person's oncologist before you prescribe that. And sometimes the oncologist does authorize it. And definitely in women who have a history of breast cancer but are not actively on treatment and are considered, right, no evidence of disease, it is considered safe to use. And I prescribe it all the time. So, yeah.
It sounds like a magic cure at the moment for like a lot of ailments. Is there any drawbacks though? Is there any concerns? If you were in front of a patient, what would you say? Sort of, there's all these pros. What are the cons aside from the breast people who have had cancer or something? To the caution, is there any others?
I love that question. This is why I am a broken record. I am a broken record about this because, like you're saying, I mean, how many treatments exist for all these problems, right? And how many problems are related to those treatments, right? Antibiotic resistance, C. diff related to antibiotic use, anticholinergic medications for overactive bladder, increased risk of dementia associated with anticholinergic medications, particularly in elderly, constipation, dry mouth. It's just goes on and on. The end of relationships due to sexual pain, right? Like, it's tremendous, the health impact and the cost and the negative results of not using this. And it is such low-hanging fruit in the medical community. I just wish it was completely ubiquitous. And I wish there was a med school course on this, but I never had. I don't know, maybe things are changing. But to get back to your question, yes, there are some counseling points I give. So one, particularly the creams can be messy, right? And people don't like having a discharge of vaginal cream. And unlike the anus, there's no sphincter, right? So what you put in kind of dribbles out. Because of that, I do typically recommend that people use it right before bed and maybe wear like a panty liner. It is important to know that the typical dose, right, if we're talking about what you're actually prescribing for an estrogen cream, a low-dose vaginal estrogen cream, is an estradiol 0.01%, and they're using 1 gram twice a week at nighttime as their maintenance dose. So 1 gram of that percentage concentration. So it's a very low dose, but they are only doing it twice a week in the maintenance dose. So it can be messy, but again, it's not every night, right? Yep. Now, if they find that very messy, there are other options, right? There are intravaginal suppositories, which tend to be less messy. And then certainly if somebody has specific sensitivities, right, that can be another downside. If somebody has a lot of contact dermatitis issues, and they may have a reaction to one of the inert parts of the base that the estrogen is in, then usually you're going to have to be working with like a compounding pharmacy to get a more inert base. So if I have somebody with a lot of sensitivities or they had a negative reaction to this, then I'm prescribing the same concentration in something really, really inert, like methyl cellulose gel. So messiness, again, skin sensitivity reaction. I tell everybody it's extremely, extremely rare that somebody, if they have, kind of a dermatitis sort of issue with it, it's extremely rare that their reaction is actually to the estradiol component. It's almost always to one of those inert parts of the cream that it's coming in. So that is something to be aware of. So that in the beginning, especially in women who are further along into menopause, maybe they've been post-menopausal for 10, 15, 20 years, and they're starting it because it is safe to start at any point after menopause. That is another point of confusion. When they start it, their vaginal wall can be very thin, so they may have a little bit of systemic absorption in the beginning. So that person might notice some, for example, breast tenderness, headache, mood change, even at the very beginning, some slight vaginal spotting. So that is important to counsel people on, because otherwise they will get very scared and they'll say, this is, I wasn't expecting this. What's going on? And they'll stop it. So that is very normal in the beginning, but in the steady state, that's not supposed to happen. And if it is happening, then, they should be counseled to contact you. So, I think that is most of it. Then, of course, there's the other concern specifically in terms of sexual activity. Does the estrogen absorb and affect, let's say, a partner, right? So the answer is that it's extremely unlikely to cause a problem, in part because it's not a strong enough concentration to cause change in blood level of estrogen, right? So it's not going to change your partner's blood level of estrogen, no matter what. But ideally, if you're applying it in the evening, and you want to have sex in the evening, have sex first and then apply the cream, right? So just don't apply it right before you have sexual activity. Or just wait till the next day, and it should be no problem. So I think those are the main factors or kind of causes for concern that people ask about, and that's how I counsel them.
With the prescription, would you almost say it's something that would be a default treatment for postmenopausal women, even women in nursing homes that might be 60 plus?
Yeah, it's a great question. In my mind, we will hopefully someday get to the point where this is discussed as preventative care. And not that we would force everybody to do it, but it's at least counseled and offered as somebody is around the time of menopause, because genitourinary syndrome of menopause is universal. Maybe people have varying degrees of, symptomatic findings associated with it, but it's universal, and it only gets worse with time, right? So those changes, those atrophic changes, only progress, unlike things such as hot flashes, which, for the majority of women improve after a period of time after menopause. These genitourinary changes do not improve. And because we know that a lot of these symptoms are so prevalent, and because we know UTIs, particularly recurrent UTIs, and the urosepsis associated with it can be so costly and damaging. And again, in the advanced, in the population of advanced age, or the nursing home population, can be associated with mental status changes, having urinary infections. I just, in a perfect world, would have everybody on this. I mean, not every postmenopausal female, or at least offer them and say, why would we wait for you to get a series of severe infections, put you on a bunch of antibiotics, risk antibiotic resistance, blah, blah, blah. From my standpoint, it's quality of life improvement, it's cost savings, it's antibiotic stewardship, with very little downside, right? And it's addressing root causes. So again, a very analog answer to your question is, I would love it to be, before women become symptomatic, I would love it to be at least an offered and part of education. We don't wait for people to have a heart attack before we assess their cardiovascular disease risk factors and try to manage them, right? Yeah.
Yeah. Well, it's been a fascinating and very thoroughly explained case that you've put forward for this. But given that Dr. Ashley Winter is not yet president of the medical world and can't put this into place just yet, what's some final thoughts or advice for general practitioners as they encounter peri and postmenopause in patients?
Just know that it's so exciting in this world to give patients solutions that address a root cause and aren't a patch on something. And when you can give somebody a vaginal hormone, it is addressing a root cause of so many symptoms. And I will tell you, it is so, so satisfying to treat genitourinary syndrome of menopause because it is so safe and because it improves quality of life. And as a general practitioner, I promise you, it will make your patient's life better and it will make your practice easier. I mean, as a specialist, I will tell you, I came into a large urology group and had women who were being treated with bladder installations, various procedures for quote unquote interstitial cystitis for decades. And I get them on vaginal hormones and they're like, oh, I'm cured by. I mean, it's just tremendous. Once you start doing it and make it a part of your practice, your patients will feel seen, their needs will be addressed. You will be receiving less calls about urinary tract infections. You will have less people getting dry mouth and constipation from their anticholinergic medications. It's just phenomenal. I love it. Your patients will love you. I can't recommend it enough. And also tell your friends.
Well, we have loved talking to you. So Dr. Ashley Winter, thanks for being part of This Medical Life.
You are so very welcome. Thank you for having me on.
Dr. Angelique Swart graduated from Flinders University in 1996 and commenced training in obstetrics and gynaecology in 1999. In 2007, following the birth of her 3 children, she completed her specialist training. Dr. Swart's areas of speciality includes general gynaecology, colposcopy, and laparoscopic surgery, including total laparoscopic hysterectomies. Now, there are a number of conditions that Dr. Swart manages, but the one we're going to focus on today is post-menopausal bleeding. Dr. Swart is our guest on This Medical Life. Welcome to the podcast.
Welcome. Hello.
Angelique, do you see many patients about peri or post-menopausal bleeding?
Yeah, peri and postmenopausal will be the bulk of the patients that I do see, definitely, yes. Yeah, it's both very problematic.
So can you give us an indication, because in previous discussions, there is a lot of variability with women on their periods whilst they're going through menopause. When is perimenopausal or postmenopausal bleeding a concern?
Okay, perimenopausal bleeding means around the menopause, so they're not quite menopausal yet. So it becomes problematic when they've got increased periods, it becomes more irregular and unpredictable, so it becomes socially embarrassing for them because they're not prepared, or it becomes heavy and irregular, which is really socially embarrassing for them, but also associated with significant iron deficiency. So that's this big problem. When you get to the menopause, which means they've stopped having periods for at least 12 months, that abnormal bleeding after that period of time is, that's more concerning, especially when it's 2 to 3 years after the menopause. That increases the risk of having dysplasia or hyperplasia or cancer.
So looking at the signs and symptoms, is there anything that should, when a GP is reassuring a patient, saying, okay, this will be a bit of a change, a bit of variation, is there anything that might raise a red flag that this is not normal menopause?
I think especially when the bleeding is at least 12 months, maybe 2 years after the menopause, so they've had no periods at all, and then they're starting to have bleeding. So it's not periods, it's postmenopausal bleeding. And it sometimes can be cyclical and it can really trick the doctors. And they think the patient comes and says, I've got my periods again, but it's not a period. It's abnormal bleeding. And so it definitely needs to be reviewed. So history, examination, and then investigations. Yeah. But also symptoms of the menopause. So it becomes concerning if a woman presents to the GP or to a gynaecologist with significant symptoms of the menopause, such as hot flushes, which is probably one of the most common concerns, and night sweats. And if they've got their hormones replaced and they are still getting significant night sweats, you've got to be thinking, hang on, is there something else going on here? You've got to be looking at, have they had a recent bowel screen? have they got breast mammograms and examinations up to date? Because there could be a carcinoma somewhere else that's giving them night sweats. They've got to be getting the whole picture.
What are the common causes for post-menopausal bleeding then?
Okay, I think atrophy, because with low estrogen, all the tissue in the urogenital area and the it all starts to get very thin and dried out, and it's more prone to tearing, and sometimes you can get bleeding from that. Particularly after intercourse, or if it becomes itchy, they might scratch, so a bit of trauma, but also other benign causes like little polyps on the cervix or urethral caruncle, which is like a little benign lump on the urethra, which on contact can bleed a little bit. But yeah, uterine polyps is another benign cause, and that's quite common. And then you're looking at, less common things are endometrial hyperplasia, dysplasia of the cervix, and then, down the track carcinoma. But, and also blood thinners. That's the other thing. I've had a couple of ladies recently, they're in their 80s and they're going, oh my gosh, I'm having my periods again. And going, well, and you've got to look at the whole picture. She's just increased her blood thinners. So, and you check for bruising on the hands and things like that, and you realise it's probably because the uterus is so atrophic because she's 80 and she's on blood thinners and she's just had a little bit of light bleeding. But you've got to exclude other things. So history, thorough examination, pelvic ultrasound, and then you think, well, no, it's probably the blood thinners.
Mm.
Yeah.
Is there any blood tests that you find useful? So let's say, assume a patient has not had periods for a year or two and suddenly they start having their periods again. Is there any blood tests that are useful for workup with these patients?
Yeah, just remember, if they've not had a period for at least 12 months and they're starting to have bleeding, it's not a period. This is where people can get really tricked. So the way to differentiate it is, and especially in women in their 50s, because you just got to think, is this periods or is this postmenopausal? So if they've absolutely stopped all bleeding for at least 12 months, they're now menopausal. They will not have periods again. Any bleeding they have is postmenopausal bleeding. And so, yes, you would be doing blood tests like, you need to check that they are postmenopausal. So do an FSH hormone level. So if they're on HRT or the pill or anything, just get them to stop all hormones for at least a week and check what their normal FSH-LH hormone is. If their FSH hormone is much higher than 30, they're going to be menopausal. So then you can say, no, this is postmenopausal bleeding, because it can be very tricky in the 50s because you get women who are still having periods till they're 57, and you get other women that, obviously reach the menopause much younger. So FSH, I find, is very useful because a normal cycle won't go above 30 usually. So if they come back with an FSH level of 40, 50, 60, they are menopausal. Yeah.
Looking at the investigations such as imaging, is there anything that is useful for the workup with these patients?
Imaging, I think the best imaging is good quality ultrasound. So you want to get somebody that has done lots of pelvic ultrasounds that's going to give you a good quality report, and they're going to be able to find ovaries. So you've got to, if they can. Sometimes it's very difficult with most experienced radiologists. They can't find it because they're so atrophic, and that's fine. But yeah, you want a good quality ultrasound because you want to look at the lining of the uterus to see if it's got to be less than 5 millimeters when they're not using any hormones. You want to be looking at the ovaries, because any tumours of the ovaries can produce, some kind of bleeding, and also looking for little polyps in the cervix or the uterus as well. That's quite common.
With the investigations, can I ask about, this will be your personal preference, do you actually like to request the blood tests and imaging yourself, or do you actually like to see a patient who's come in with it, the GP has already ordered it?
Well, it's very useful if the GP's already ordered it, because then you've got the results there and it just speeds things up a bit. So, yeah, definitely. So, if someone's had lots of bleeding, iron studies, blood count, do thyroid function as well, because women in their 40s and 50s, 1% of them will have abnormal thyroid function. That can cause abnormal bleeding as well. So if they've got all of that done and a good quality ultrasound, it will actually speed things up a bit, because it means the patient doesn't need to come back for that second visit, which is cheaper for the patient too.
Now, one of the things you mentioned, and it will certainly be a lot of on people's mind, postmenopausal bleeding and the concern about endometrial hyperplasia and carcinoma. Now, how common are these as diagnosis for patients in postmenopausal bleeding?
Endometrial, it's not that common. It would be less than about 10% of patients that come in with postmenopausal bleeding will have hyperplasia. And then carcinoma is much less than that too. So much less than 5%. Yeah, it's actually quite, it's uncommon to have hyperplasia and it's rare to have the carcinoma. Yeah.
If we just touch on this, because this hyperplasia and carcinoma will be certainly a topic in the future we cover. But is there many treatment options available for these patients?
Oh, yeah, definitely. I think with hyperplasia, first, getting the diagnosis, it's definitively diagnosed by having a hysteroscopy and taking biopsies. But a lot of the time you can actually do a thorough curette, remove a lot of the hyperplasia, whatever, and then it's really beneficial putting a Mirena in. Mirena is really effective at reducing any reproliferation of any of this hyperplasia. It works very well, particularly in those women who are not suitable for hysterectomy. But you do have to have follow-up. 6 months later, do a repeat hysteroscopy biopsy and then just check to see if it's regrown. And then if you've got at least two tests 6 months apart that are completely benign, you can then go and do a repeat one in 2 years. Or if the woman's sick of all that follow-up, she can just say she wants to have a hysterectomy. But most of the time you don't need to have a hysterectomy for someone that's had hyperplasia.
Angelique, thank you for your insights and your clarifications in our chat. But before we close, do you have any final advice for general practitioners, especially when it comes to managing patients with peri and post-menopausal bleeding?
I think don't underestimate the benefit of doing an FSH hormone, because I know a lot of the GPs don't like doing it, but it's so useful because, I get the occasional referral of a lady that's, 58 and told she's having abnormal periods, and she's actually had postmenopausal bleeding for a year or two. So, it's really useful if you just stop all their hormones and then do an FSH hormone level. And then if it's way above, 30, 40, 50 or whatever, she's menopausal. This is not periods. Yeah, I think that's the biggest thing that I would like to mention and warn people. Yeah.
And look, that certainly came through loud and clear in our chat this morning, so thank you for that. Dr. Angelique Swart, thank you for joining This Medical Life.
Thanks very much.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts via Twitter. Dr. Travis Brown is at Dr. Travis Brown. That's DR for doctor. And Steve Davis is at Steve Davis. Editing and production is by Tim Whiffen. Design is by Tom Buzenjut. This has been a Pathnotes Proprietary Limited production.
Love this podcast? Support it and sponsor today. Simply head to AuscastNetwork.com for details.